This is the surgery of a 75-year-old female with a history of bilateral fungal keratouveitis from long-term uncontrolled steroid use in a form of topical ointment. And after having the infectious keratitis that left her blind in both eyes, we decided that this eye, her right eye, was amenable to surgery. So we started with a fine needle diathermy to cauterize some of her vessels to maybe reduce the risk of rejection post-operatively. We're trephining up to a depth of 700 microns, lifting up on the trephine. We get a nice centration, and then although we've used up all of the trephine rotations, we still haven't entered the AC, the cornea being very thick. So we stab at one point in the trephination groove, we inject viscoelastic, and then using standard PK technique with scissor to the right and left shown at this moment, we excise the donor button, and we expect to find multiple anterior and posterior synechia from the long-standing anterior uveitis. This surgery is done under local anesthesia because of general health concern risks that were deemed too risky by our anesthesia team. So what we find is that we've actually incised an intracorneal plane, and we're still to reach the anterior chamber. So using another stab incision, we find the correct plane anterior to the iris, and then we're bluntly dissecting the anterior chamber. Basically, we're used to these kinds of maneuvers from Dalk intrastromal dissection, but we're using the same technique to dissect iris off of probably a retrocorneal membrane, and peeling it off using at the same time mechanical forces and the Vanna scissors. We identify what is the anterior chamber, and we observe a pupillary membrane. What is very surprising is that this patient didn't have ocular hypertension, although she appears to have had pupillary seclusion and occlusion. So we're excising this membrane using the 15-degree blade right at the pupil margin. We find that this technique, even though it looks traumatic, is a bit more controlled, preserving more iris tissue. We get a glimpse of what is a red reflex with a yellowish tint, probably because of the long-standing inflammation that has left vitreous debris visible on ultrasound. And now we proceed with suturing of the donor graft in standard fashion. 1 month and a half after this surgery, the patient develops a hyperacute stromal and endothelial rejection that we're still currently managing. This being her only seeing eye, we try to do something to preserve the globe because the whole graft is melting at this point, and to do some sort of conjunctival or amniotic membrane temporary fix until we can either try to do a PK again or maybe a K-Pro. Now this surgery is being performed about 8 months after the initial infection, for which the patient was kept on topical amphotericin B and oral voriconazole for at least 3 months until the infection settled. And then, after the infection had completely settled, we waited for another 6 months until we did the final surgery. So for this reason, we're not administering prophylaxis with antifungals in her case right now. Thank you for watching.